In my presentation, I'm gonna talk about complications in treatment of ischemic strokes. They are gonna be subdivided into three parts. These are reperfusion complications and other complications related to contrast injections. Most likely, we face the first two kinds of complications. Such inter-operational complications may start at the time of forming the access. They involve hematomas and or as ruptures of iliac arteries when the operator being concentrated on the thrombectomy may neglect the problems with iliac artery, since we are talking about rather elderly patients, and feeling the pressure, they neglect it and result in the perforation. And you'd better perform the proper prophylaxis of such complications. So if you have problems with iliac arteries, you have to perform the angiography and see where the tool goes, and see if there are any stenosis. And in case you have a rupture or a dissection, you have to perform a balloon angioplasty, and using a peripheral catheter of about 10 millimeters diameter at low pressure, and the blood bleeding has stopped, you'd better shift to alternative approach and perform mechanical thrombectomy from cerebral arteries. And when the blood flow is restored, you can come back to the iliac arteries and reimplant a stent graft. When you catheterize the arteries, you may dissect the carotid arteries as well, include the occluding or non-occluding lesion. The tactics here is determined. If it's not non-occluding lesion, you can put the guide wire catheter to perform thrombectomy from the intercranial basin, and then go back to extracranial section and decide if the dissection is preserved. You may perform prolonged balloon angioplasty, but if it doesn't help, you may perform implantation of a stent. In case of an occluding lesion, like in this case, you should immediately perform balloon angioplasty at low pressure and wait for 5-7 minutes. And in most cases, this section closes and you may continue the treatment. Dissections may also be caused by the guiding catheter or during thrombo instruction. The most likely position of the occluding catheter is here to shorten the pathway, but things we're dealing with patients, and many of them are sufficient tortuosity of the carotid artery, and we put the catheter in a low position and input the stent retriever, and removing the stent retriever. It works as an anchor, pulling the stent retriever, causing this kind of kinking, and trying to pull out the stent retriever in such a position, you can cause a distant embolia, and even dissection of the internal carotid artery. So in this case, the optimal course of affairs is to use distal catheter or an aspiration catheter in combination with an occluding guide wire. Perforation of intercranial artery varies from 0 to 4% according to literature, and it's quite a serious complication because it may result in mortality in 60% of cases. The reason of such a complication is a quite a rough performance of the procedure using the non-specialized tools and the presence of sufficient tortuosity or atherosclerotic plugs, improper assessment of the tools and use and the cerebral anatomy and sometimes you can perforate the vessel beyond the zone of occlusion. Prophylaxis is the best way of action. You can act properly and use the proper instrumentation. So if we start catheterization, usually it's done in direct projection in order to pass the cavernous sinus. You'd better not to be lazy and perform a lateral projection as well to clearly understand where your tool's gonna go, because rough manipulations in this area can result a in the formation of a fistula. And after you've put your instrumentation over the supraclinoid segment, you can clearly understand whether your tool goes in the cerebral artery, because it starts to go vertically. It might mean your micro catheters has entered small vessels, which may result in formation of a hematome. We had such a complication that you can see the posterior cerebral artery occlusion, and when entering the microcatheter, we could see the extravasation of the contrast. And since the microcatheter was already in the vessel, we've decided that stent retriever implantation will allow us to close the dissection, and what was done, and an uncontrolled angiogram has shown no extravasation, and we were hopeful. And in this case, the all method of stent assistance will let us stop the blood flow. But when in 5 minutes we retrieved the stent retriever and prepared the balloon, we tried to perform the tromp instruction from the posterior cerebral artery, and what we got was a recurrent bleeding. But since we had the balloon, we inflated it in the dissected area and waited for 5 minutes, and on a control CT you could see that the dissection got completely occluded. This was the control CT, and you could see the quite excessive SIH, but in 16 hours, the CT looked pretty normal. The most commonly dissections and perforations occurred in MT from distal sections of posterior cerebral or anterior cerebral artery. This is due to anatomical factors, thin walls, and according to the literature, more often than not, such complications occur than in case of mechanical thrombectomy from M1 segment. Such complications we didn't observe. So what I demonstrate here, the experience of our foreign colleagues who brought us their webinars last year. There you can see such a case. During the fast passage, they successfully restored the blood flow. That the operator didn't like the emboli in the M3 segment of the MCA, and they decided to perform mechanical thrombectomy from this segment. And when putting the micro catheter and the micro guide wire, they had a dissection of they had a dissection most likely due to the stressed guide wire, or the so-called laser effect of the micro catheter. And in this case, the operator had nothing to do but to occlude the MCA using the coils, since it was the only way after the perforation. Another complication that is related to dissection and rupture of the distal sections of the MCI. In this case, this is the occlusion of the terminal segment of the internal carotid artery. What we see here is the emboli in the temporal occipital part, and the due to unsuccessful mechanical thrombectomy. And as I told you, it could cause the spasm, and that's what happened in this case, and ended up with the dissection of the cerebral artery. The main course of action here is to carefully assess the risks and the potential benefits of mechanical thrombectomy when you're trying to extract the thrombi from the distal sections, and when you localize occlusions in distal areas, your method of choice should be an aspiration technique and aspiration catheters. What are the predictors of SIH in case of straight retrievers? That's the number of passages more than three set in the stent retriever and an M2 segment, and the hours before stent retriever removal. This year we have seen this publication in Stroke, where the author have demonstrated that mechanical thrombectomy with more than three passages has significantly increased in 3.5 times of systematic SIH. And which means if you tried two times, you probably have to stop or shift to another revascularization technique. Another complications, either thromboembolic complications in use of stent retrievers. All thromboembolic complications of that kind can be divided into and thromboembolic complications in early occluded areas when emboli develop in these core branches, or when embolies occur in non-occluded branches. Sometimes these two emboli might combine when they could simultaneously occur both in anterior and posterior CIs, and may sometimes due to excessive tortuosity, like in this case. In this case, they use this Lumbra technique, but as you can see, the emboli occurred in the I4 and of anterior and posterior CIs. In this case, we decided not to risk and not to remove the thrombi keeping in mind the high level of tortuosity and the age of the patients. And we were right in this case because the patient's neurological deficiency regressed in a fast way and no ischemic zones appeared. So, most likely, the collateral blood flow compensated the damage. Um, uh, Thrombotic complications frequency varies from 3 to 11% in different publications, and the most damaging one here in this respect, it's the emboli in early non-occluded segments. The frequency of such complications is around 20 percent, and it commonly involve tandem lesions of anterior and posterior CI, and such complications significantly increase the risk of unfavorable functional outcome and hemorrhagic complications and mortality in two times. It's very important proper prophylaxis of such a complications. It's the proper blockage of the blood flow before you open the stent. And after you implant on the stand, it is recommended to wait at least 5 minutes in order to see if the thrombi we have distracted is not consolidated in the stand and reduce the risk of thromb immigration from a stand retriever. And of course, you have to block the cerebral blood flow as it was done in the in vitro study, um, and is proved to be the most inventive technique in this respect. Unfortunately, cerebral blood flow blockade doesn't always isn't always effective, since patients may have a closed circulation of anterior and posterior CA circulations, which may um, present the risk of this kind of emboli. And the most effective method in this choice, in these two combine, including guide wire catheter and aspiration catheter, in order to reduce that risk at naught. This is the so-called SIFE technique. In presence of distant embolies, we um, have to uh, um, continue mechanical thrombectomy to dissolve the thrombi anyway. Reperfusion complications and hemorrhagic complications. In year 2000, it was offered to subdivide them into four different classes. This is hemorrhagic transformation of the first and second type, when we see a small bleeding manifestations, and hematomas of the first and second type, when we see those hematomas that take less and more than 30% of the ischemic damage zone. In 2015, another classification was offered that widened the previous one. This time it involved three classes. These asymptomatic hemorrhagic transformation. Um, the second class, that's the parahematosic hematomas of more than 30% of the ischemic volume. And the third type, there's different kinds of bleedings that are not related to ischemic zone. What are the factors that affect the frequency of bleedings in different authors? They're described in different way, but for instance, in this article, it's diabetes mellitus, the number of stent retriever passages, and taking and anticoagulations were the important factors of bleeding after mechanical thrombectomy. In another study, the high level of glucose and low uh, aspect was the were the key factors. Smoking aspects, common anesthesia, poor collaterals, embolia in the new territory also were the decisive factors. Lately, a lot's been said about that high systolic blood pressure after successful reperfusion may be a predictor of bleeding. Um, in this study, for instance, that the systolic pressure over 160 millimeters of mercury um, can be a predictor, while in another work, it was shown that such a systolic pressure increased the risk of bleeding 6 times compared to patients with a blood pressure at the level of 100 to 120. This is another similar publication that says that systolic pressure over 160 affected the frequency of bleeding significantly. And if we sum up what's been published, we can say that for prophylaxis of symptomatic hemorrhagic transformation after mechanical thrombectomy, we might consider the first pass effect, and if and the first pass effect is a very important factor no matter what technology you rely upon. You have to control blood pressure, and if you've successfully performed a reperfusion with the optimal level of 100 120 millimeters of mercury in the first 2 days after the thrombectomy, you have to control the glucose level, and you have to minimize using of disaggregant therapy, which can only be used in case of stent implantation. And for the time being, there is no any protocols I could recommend. When should you implant a stent of into an internal carotid artery? In the last 2 years, they used the following combination. We put patient on aspirin through the zone, and induce half bolus of glycoprotein receptors blockers. Then we give them half of bolus glycoprotein receptor blockers, and our philosophy then requires that aspirin starts to work and we stop giving the blockers. Then we perform CT in 12 hours, and if we see no bleeding, we put the patient on a standard dose of Plavix. According to the recommendations, the frequency of hemorrhagic manifestation should not exceed 10% in average. Thank you for your attention.